Starting now. So welcome everyone to today's second installment of the COVID-19 Lunch and Learn series. Today we will be discussing reproductive telehealth with the wonderful Dr. Amy Potter. I want to remind everybody that before we get into it today, if you have any questions, please submit them through the chat. You can submit them directly to me. You can submit them to the entire group, whatever you feel most comfortable with. This conversation, I don't know where it's going to go yet, but I have high hopes that it's going to go pretty well today. So a little bit about Dr. Amy Potter. So Amy Potter is the medical director of Planned Parenthood of Central and Western New York. She is a family medicine doctor originally from Albuquerque, New Mexico. She went to college in Philadelphia and then worked for a few years as a sports writer, which I thought was very interesting, but ultimately decided to pursue a career in healthcare. After graduating from medical school, at the University of Rochester in 2011, she completed her internship and residency at Swedish Cherry Hill Family Medicine Residency in Seattle.
She has
a special interest in reproductive social justice and integrative medicine and substance abuse disorders. Dr. Potter is a clinical instructor in the Department of Family Medicine and Pediatrics at the University of Rochester School of Medicine and Dentistry, which I didn't know the two were combined, so interesting there, and a clinical faculty member at the University of Buffalo. She currently lives in Rochester with her husband, Kevin, and dog, Eddie. I please hope you included a picture of your dog.
Oh my goodness. You know, that was such a good entree. Usually his dog walker comes and picks him up by like noon, and she just texted me that she's running behind. So I very much apologize. I don't know if you can see him on the chair over there. He looks very lazy right now, but when he decides to bark, he's very loud. So I preemptively apologize if we hear from Eddie during this discussion.
There's more to add to the conversation.
Exactly. I was like, oh, good. I'm glad I included him in my bio because he may come up a little bit later. Well, thank you so much for that introduction, Samantha. I really appreciate it. And I'm really excited to be here with you all today. I took a little time to look through the website and just get in a kind of an idea of what this group is. I think one of the most fascinating parts of my job, which I'll kind of start introducing what my job is, in the sense that I oversee Planned Parenthood of Central and Western New York, which includes 9 clinics and 1 mobile unit between Buffalo, Syracuse, and Rochester, and kind of all of the counties and areas in between. So we have a wide geography, and I do live in Rochester, and that's where I've practiced medicine for about 7 years now. And so what I love about this is getting those moments or those opportunities to kind of touch down and better understand the healthcare systems in those other cities where I'm technically supervising care, and it feels so disconnected at times to not be embedded in a part of that medical community. So I was excited to have this opportunity. So I thought I would I kind of went through and thought about what we've done in the past 6 to 8 months and kind of tried to create some highlights around that. So I'll start out talking for a little while here and give you guys kind of a 30,000 foot view of what services we were providing before COVID hit, and then how we've had to adapt. And really, I would say the theme of the past 8 months has been thinking on our toes and being as creative and nimble as possible, which for those of us who've been in healthcare for long enough, I would not necessarily use the words creative and nimble to describe healthcare at any point. So that's, I think, been the challenge is finding ways to adapt quickly to a landscape and a situation that seems to change for us, certainly in the very beginning weeks, every 24 to 48 hours. So I'll start out kind of talking through that. And then, I think these are most useful when you guys get to ask me what's most relevant and important to you to know about as well. So I'll kind of keep an eye on the time and try not to hog the hour. And at least keep about 20 to 30 minutes for you guys to pepper me with questions. I also will say, Samantha, if there's some really great questions that come up in the chat as I'm talking, if you want to lift those up or interrupt me, I'm totally open to that too. So
absolutely. Just a reminder, everyone, please, if you have questions, don't hesitate to ask. That's what this learning hour is about, is to learn. And how do we learn if we don't ask questions?
Exactly. And I'm very good at talking. It's one of my strengths, but it also means that I can tangent and talk about what seems interesting to my brain in the moment. But I want to make sure this is relevant and helpful to you all. So please feel free to interrupt or pepper in with questions. I think it'll make it a more robust discussion. So as I said, we have 9 clinics across Buffalo, Rochester, and Syracuse. We do have 4 of those clinics in the Erie and Niagara counties. So we have a clinic in West Seneca, Main Street, North Tonawanda, and Niagara Falls, which some of you may be familiar with, but just in case, I just wanted to give that 30,000-foot view. We also have a clinic in Batavia, and then clinics, further out east in Rochester and Syracuse. And before COVID, we were really doing the vast majority of our care in person in our clinics. And our care goes beyond strictly, I guess, what I would call reproductive health. I think, a lot of people think about Planned Parenthood, and they obviously think about birth control and contraception and STI screening and testing and treatments, and obviously abortion care as well. And we certainly do all of those things, and it's a really important part of our work. But we do a lot of other things too, including, well visits, pap smears, well care for breast exams. And we've also been trying to kind of expand the services we provide to our male patients, and really have robust services for our male patients to come into. So this year we've really tried to work to make sure when our male patients are coming in with reproductive or any sexual health concerns that we're able to adapt and respond to that. And then, as I mentioned, and I put this in my bio for a reason, I'm a family medicine doctor by training. And so I think it's very important, and I'm sure you guys probably would all agree or have heard this repeatedly in your own work, that there are opportunities to do health behavior change in every single type of visit across all of medicine. So it's been a real, I guess, mission or goal of mine to incorporate the type of health behavior change care that we can into our visits. And there's some obvious tangents there that make sense, right? Obviously, if we're talking about sexual health behavior, condom use, that's an easy leap. But we've really been expanding too into emotional health care, into talking to people about mood, and also talking to people about how to take care of their bodies in terms of weight, nutrition, and then lastly, tobacco cessation counseling. And I really think all of those things funnel really nicely into this bucket of health behavior change. And I don't care if we're talking about quitting cigarettes or vaping or weed or losing weight. The techniques and the tactics that we use in the exam room are pretty much all the same. It's just a matter of kind of helping to work and identify with the patient what is the most important thing for them to be working on that day and what they can identify as their goals or techniques to achieving that health behavior change. So that was our context going into COVID. And then obviously COVID started to hit, and we realized that we needed to adapt and respond quickly with 2 primary objectives. The first was to obviously decrease risk to our staff and to our patients for transmission of COVID. So, if somebody was coming in for, say, asymptomatic STI screening, like, we're all about the fact that they're taking care of their sexual health and want to get screened for STIs, but does that need to happen in the middle of a pandemic? So thinking, are there ways to mitigate risk when maybe the reason for the visit isn't super acute? So that was kind of the one part of the balance, is decreasing risk to our staff and our patients. And then on the other side of that balance, I see as maintaining access for the vital services that we provide. And part of that is also decreasing the burden on our urgent cares and emergency departments for services that we can actually provide in our outpatient settings. So at every moment in our response, we were going, okay, are we mitigating risk for our staff and our patients, but are we also making sure that we're keeping our doors open so that folks who are in vital need of services can get it, and we can help the emergency departments from getting too busy with stuff that could be seen in our offices when they really need to focus on these very sick patients in our community right now. Let's make sure we're doing what we can do to make sure the EDs can respond to COVID. And my examples here are, we can take care of UTIs. Now, I get it. I know why people go to UTIs or go to the emergency department for UTIs. If you've ever had one, it's terrible. You're like, this is the worst. This needs to end right now. And so it is very urgent to the patient. And so it needs to be seen, but it's not necessarily acute enough that it has to be seen in an urgent care or emergency department. So all of our response really tried to weigh those 2 parts of the balance. And what I think is most important about all of our response to COVID is that that balance was not static. So from week to week, it was a constant, ever-changing balance of what did we need to do to keep our staff safe, but also what do we need to do to make sure that patients are getting seen in the community and not getting abandoned. And obviously with COVID, we have had a highlight or a spotlight on inadequacies and certainly breakdowns in the infrastructure in our healthcare system, specifically around race. And we've seen how that's impacted folks with COVID. And what I know is it's going to have the same exact impact on folks who need to be seen for a UTI, who need to be seen for abortion care, who need to be seen for contraception immediately. So I felt it was really important to stay open, even though there was obviously some risk there. So the major things that we did to respond to COVID was to massively ramp up our telehealth program. So prior to COVID, we were doing a little bit of telehealth, but it wasn't truly telehealth like we would think about it now. What we were doing was actually using telehealth, like iPads or, what am I trying to say? iPads. Anyways, to communicate between our clinics. So previously, maybe we would have a nurse who knows how to ultrasound sitting in the office in Batavia, which is one of our smaller offices and has fewer visits than our Main Street office in Buffalo for obvious reasons. There's just different populations there. So what we had done previously was maybe have a nurse who knows how to ultrasound sit in that Batavia clinic, but then she would be able to telehealth to a nurse practitioner or PA provider sitting at Main Street in Buffalo and say, hey, I did this ultrasound, this patient would like to do a medication abortion today. Can you order the medications? And then we would telehealth the provider to that patient sitting in Batavia. So we had been doing what we called site-to-site telehealth before COVID. So that helped us in the sense that we had some of the hardware and actual physical stuff that we needed for telehealth visits. And we had actually already started playing with some of the software or, the different video systems, Zoom, Doximity, there's all these options out there. And we had been playing around a bit with that software, which I think positioned us to be able to then really create a true telehealth program. So we had some foundational steps set up, but then we really launched into a whole new space once COVID hit. So probably about 2 to 3 weeks into COVID, we realized we were really going to need to ramp up telehealth. At the same time, we got, well, sort of not exactly the same time, but sort of in step, we also got reassurance from New York State that they would begin to compensate telehealth visits as they compensate visits in the health center, which was a really important part of our financial viability and being able to keep our doors open. So that was another pivotal step. And then we did a ton of operational and organizational work to create a telehealth program. And there were tons of logistics from technology ordering, having to get a lot more tablets and pads to use. We did a lot of troubleshooting with different software systems. Some of them dropped a lot of calls and other ones didn't drop. Some seemed easier for patients to access and use from a wide range of devices. Very rarely are patients calling into us with 2 screens and a desktop. That's, they're not calling in from their home personal office often. We saw very early on in our telehealth visits that we were seeing, most of our patients by their phone, by the screen on their phone. A lot of patients who sneak out into their cars on a coffee or on a break at work, or, if they've got 5 or 10 minutes, they can maybe sneak it in. One of my colleagues said, yeah, I saw someone in a butcher freezer because that's where she could find some private space at work for a 15-minute appointment in the middle of her workday. Exactly. So we started playing around with different systems to see what worked best for both our end and also the patient's end. And then what became really important to identify is what visit types we could see by telehealth and what we really felt required the patient coming into our clinic. And I will say I tend to be, I don't like to put really hard lines in the sand, because I really do believe that the best possible care happens for a patient when it happens on the terms that work best for them. So instead of creating like a hardline rubric, if this patient has this, they have to be seen by this, we created some soft suggestions. But I essentially said, if any patient wants to start their care with us by telehealth, that's fine, right? If Samantha calls into me and we talk and I identify she has a concern that I really think I need to see her in person for, I'm going to say, hey, Samantha, I'm sorry, this was really helpful. I have an idea of what's going on, but to really understand what the plan's going to be and what we can do to make you feel better, I've got to have you come in. And I don't see that as a wasted visit. In some ways, I see that as building a good therapeutic relationship between the patient and the provider, and being able to say, hey, we can meet your needs right now by this screen, or be able to say, in order to take safe, competent, and high quality care of you, I've got to have you come into the office. So I think it may be helpful to kind of hear some of those visit types and how we've been triaging them. But essentially we said, if all you're calling for is your birth control refill, can we please see you by screen right now? Because it turns out there's really not a lot, especially when we're talking about women of reproductive age. The vast majority of women of reproductive age are healthy. I'm a family medicine doc, so I used to take care in my previous job of the whole cycle of age. And, women of reproductive age are just healthier than most 80-year-olds. And so, you can really do a lot by that screen, especially when it comes to getting women the services they need, particularly with regards to contraception. There are real consequences to delay in care, and truly very little risk to starting most women on the vast majority of those medications. So we converted most of our contraceptive visits to telehealth. So that includes, prescriptions for the pill, prescriptions for the ring and the patch, and then also just counseling visits. A lot of times people just want to talk about what their options are. And in some ways, I actually think telehealth visits are like a real opportunity here, because there is sometimes that feeling in the exam room of the provider has an agenda and like they want me to pick a birth control visit today before I leave. And in some ways, the screen like takes that all out. I've done a number of visits where people are like, I just want to talk through what the options are. And I kind of think it decreases the pressure when I'm by screen. I'm not forcing anybody to choose anything today, but it can allow for this really nice kind of open discussion, open-ended questions, motivational interviewing, and really be able to meet the patient's needs, even if that doesn't end up in a prescription that day. And then also we did counseling for contraceptive methods. And if folks identified that they wanted the depot shot, the provider on the computer screen said, great, I'll go ahead and order your depot shot. I've reviewed your medical history. There's no contraindications. You can proceed with this method. And then that patient actually was scheduled for a nurse-only visit. So walked into our health center, the nurse had the prescription on file or has the prescription on file. The patient walks in, gets the shot, and walks out the door, which just vastly decreases the amount of time that they're in our healthcare center and thereby their risk for COVID. Emma, I just pulled up your question and I love it. And let's hold that question because my short answer is yes. But let's hold it till the end because I may actually also ask Chris Spicer, who I think is on this call, to jump in because we're also now we have a grant and are thinking about, okay, how do we expand access to telehealth services for all of our patients? But I actually really do think this is an opportunity to reach more patients, 100%, particularly younger patients. Other things that we can do easily over the screen for telehealth, emergency contraception, easy peasy, which also is over the counter. And we remind people of that all the time, but sometimes people want to talk through it, or sometimes when we send a prescription or they walk into a health center for a prescription, much like the depot shot, they can access it for a much smaller fee to them or free, depending on their status. We also allowed people to do PrEP visits by telehealth. PrEP is a once-a-day tablet that you take to prevent HIV transmission. And again, there's not a whole heck of a lot of exam component or real need to see people in person. There are some lab work, there is some lab work that needs to be done for PrEP to make sure that it's administered safely. But we just figured out ways around that. Okay, so we're doing this by screen. We're going to order that lab work directly to the lab. Maybe you can go to a nice outpatient lab facility, get in and out, and then we can send your prescription in. So for some people, that's a much easier way to manage it. And also, I think that, interestingly, I could go off on so many tangents here, but that also kind of breaks down some of the decreased access geographically, right? So if you're in a more rural area and it's been hard for you to drive into the city and get services, all of a sudden you can do this by screen and go to a lab. You know, we have a lot of patients who drive to us from areas like Jamestown. And so now maybe you can just go to a lab in Jamestown and get your lab work done and get that prescription sent over to your pharmacy. That's a heck of a lot easier than having to figure out a way to drive into Buffalo. We also did options counseling. We also do options counseling for pregnancy by telehealth. So some people take a pregnancy test at home and they just want to know what their options are, right? Maybe they're undecided. Maybe they don't know what they want to do, but they want to know, if I did want to pursue an abortion, what does that look like? What does that mean? What would I have to do? What are those steps? And then again, doing STI screening, we can't actually complete the screening on the screen, but we can send people to the lab or have the order already in our computer system. That patient walks into our clinic, we hand them a little urine cup, they give us a donation, and they walk out the door. So again, decreasing the burden of risk for both our staff and for those patients themselves. And then the other thing we have been doing completely by telehealth is some minor infections. So, you know, for people with vaginas on the phone, bacterial vaginosis and yeast infection is super common. It just comes up a whole heck of a lot. And a lot of people with vaginas have had multiple infections of that type. And so we decided early on that, you know, with the appropriate evaluation by telehealth, we sort of trust women to report those symptoms. And we trust ourselves to have a pretty good gestalt for what needs to be treated. So, you know, people call in and they report the classic symptoms of a yeast infection and they say, I always get them after I take antibiotics and I had antibiotics 3 weeks ago. We said, okay, we're going to send in the treatment for a yeast infection, which is also a pretty low risk intervention. With the caveat that we document and really go through with the patient of, if this doesn't work, please call us. And then we're going to bring you in and then we'll actually do a swab and we'll do some lab work to determine or clarify a diagnosis. But I'd say for the vast majority of the women, that works, right? A lot of women know when they've got a yeast infection, and a lot of women who've experienced bacterial vaginosis know when they've got that and know what they need to have it treated. And I trust people to identify that. In terms of things that we can't do by telehealth, there are things, and I think that's been really important for us philosophically to maintain presence in all of our communities throughout this, because when people have immediate concerns in these areas, they are not things that they want to defer. So, you know, obviously the things that come to mind immediately is abortion care, right? And when a person is pregnant and they don't want to be, that is not something that can be deferred for medical reasons, but also emotionally and psychologically, it is damaging to defer for a long period of time. We have the goal within our own metrics at Planned Parenthood of Central and Western New York to get all patients in for an abortion appointment or just abortion evaluation to talk about abortion within 7 days for that reason specifically. And that was probably the toughest thing for us in the past 8 months to maintain, between staffing concerns, you know, and just everything happening with COVID, with kids being home and people trying to be caregivers and also maintain their jobs. Getting people in that window of time has been a challenge for us. But having provided care to many people who need to not be pregnant when they are, every day can really feel like torture when you know that something needs to happen or something needs to change. That prolonging can be really difficult emotionally and psychologically. So getting people in for abortion care remained sort of top on our list of things that basically only we can do, that otherwise people in our community will have a very hard time accessing. That's particularly true for us in Syracuse, where there are essentially no abortion services other than us. In Rochester and Buffalo, there are a few other abortion services, but we do the vast majority of that business, so maintaining that access. And then the other thing I feel really impassioned about is maintaining access for long-acting reversible contraception. So for those who don't know, we abbreviate that in medicine to LARC. So if you hear LARC, we're talking about two things: IUDs and implants. And those are the methods that you can put in one time and last for years. And I think some people would argue, is that really urgent, or is that really acute care that needs to be done in the middle of a pandemic? And my argument is absolutely. I actually have their permission to divulge this. Literally in the first 3 or 4 weeks of the pandemic, I put in about 4 IUDs for my friends who work in ICUs and work in hospitals, because they were like, you know what I need is to not get pregnant right now. Like, that would be the biggest disaster. Like, I need to be able to control that one thing as I start to work back-to-back shifts and work overtime and work tons of hours. So I just thought that was really, I was like, this is peculiar. All of my friends are texting me for IUDs all of a sudden. But I think that goes to show that when there's uncertainty in our world, it turns out that people still want to be able to control their reproductive health, and even maybe more so when they're less able to control other things happening in the world, which is basically like the definition of 2020, right? We have no control anymore. So LARCs and abortions remain top on my list. We also do not defer follow-up for pap smears that have been abnormal. So anything that is kind of in the pre-cancer or concerning for cervical cancer zone, that's stuff that cannot be deferred. We've also encouraged patients who are supposed to come in for earlier follow-up than normal for their pap smears if they've had like minor abnormalities. We're like, don't skip that follow-up. That really is care that needs to be done. And then obviously infections. So UTIs, any sort of STI infection, any concerning symptoms from an STI, and vaginal bleeding. And those are the areas where I really see us helping to decrease burden for our emergency departments as well, because a lot of people go into emergency departments for those complaints. I'm obviously closer to the systems in Rochester because that's where I live, but we've had some direct funneling from the emergency departments to our clinics. They check in and say, I think I have an STI, and they say, well, you'll wait 7 hours here in the emergency department today, or we can get you seen at Planned Parenthood in the next half hour. And we kind of, take that patient over. And then last but not least, any concerns for breast finding. So if somebody identifies a new breast lump or new discharge from their breast, anything that really could be concerning for a pathology like cancer, we do not feel that should be delayed in any way, shape, or form. So we've continued to see patients in clinic for that. So I'm trying to just think here. At this point, I thought it might be helpful to hear that at this point in time, we've been fluctuating over the past 6 to 8 months, obviously as COVID fluctuates too, right? But we're averaging about 11% of our visits by telemedicine. I think in the height of April and May, that was probably a larger percentage, up to about a quarter of our visits. And we're again here now in this second wave, starting to ramp up our in-person visits again. One of the real perks that I've seen, we rolled out doing gender affirming hormone care at our Syracuse and Canandaigua locations about 2 years ago. So providing masculinizing and feminizing care for trans and non-binary folks. And we'd really identified that Syracuse and Canandaigua were the communities in the most need. Rochester and Buffalo do have some providers there. So we felt like, let's start in the place with the most need. So doing it for about 2 years, but I've had this feeling for 2 years of, okay, I want to get it. I want to get it out and across this region. And what's been really fascinating about telehealth is, hey, we can't identify where someone is coming from when they call us by telehealth, right? We can't necessarily say, oh, we won't see you because you're sitting in Buffalo right now. It doesn't matter anymore. Whereas they used to have to actually drive into our Syracuse clinic or drive into our Canandaigua clinic. So it's actually, by default accomplished another goal of mine, which was to try to expand our gender affirming hormone care imprint across this region. I think this has opened up opportunities for us too, moving forward, to really kind of do some work to understand those communities better, get more of our providers trained, and expand those services, which is not to sort of cut down the other places that do those services in Rochester and Buffalo. In fact, my husband works at the Rochester one. It's called Trillium Health, and like that's their game. And he would say it, and I would say it. There's plenty of business to go around, and so much unmet need in this community. So I think the more that we can do to meet that need, the better it will be, and only beneficial for everyone. So I think the other thing I just wanted to mention is we're doing a lot of things to try to keep our staff safe. And I think the biggest change for me in terms of anxiety between April and May and now is that we have increased, we have data from early on and data that shows us continuing that transmissions are not happening in the healthcare setting. So I do feel reassured that the measures that we've taken to keep our staff safe in terms of PPE, in terms of mask wearing, in terms of social distancing, our patients in the waiting room, and other physical interventions that we've made, I feel good that we have not seen much transmission in the healthcare setting. Unfortunately, right now, I think what we're most concerned about is what happens when we all go home and aren't in full PPE and go into the grocery store and trying to manage our lives. So, wow, that was a lot of talking from me. Let's see here. I'm just going to peek over here and see if there's anything else I meant to say. Oh, the only other thing I meant to say is we did do a few things to try to decrease the need for patients to come back into our clinic when we needed to see them in clinic to start. So for medication abortions, we always diagnose a pregnancy using an ultrasound. And previously, before COVID, the only option for follow-up was to come back into our clinic and have a repeat ultrasound done, which showed there was no longer a pregnancy inside the uterus. Early in COVID, we implemented a follow-up system by urine pregnancy test at home. So instead of that patient having to come into us for a second visit, we instead did follow-up by telephone and actually handed them a little pregnancy test to take home with them, said, keep that. You're going to take it in about 4 weeks. We called them, said, did you take your pregnancy test? Most of the time they haven't. Say, okay, we'll call you back. They go take their pregnancy test. And as long as it's negative, they're good to go. And if it's positive, we have, ways to identify if we need to see them back in clinic or if there's a complication happening. So just trying to think of little ways like that, whether it be medications or, something like that urine pregnancy test. What are the ways that we can decrease the need for patients to come back in when we maybe could get that information another way? Super. So I think I'll stop talking for a moment and let people jump in with any other questions.
That was a very engaging discussion on telehealth. As someone who currently has like a LARC, I'm always interested to see kind of what those trends are. For anyone who's at UB and considering pursuing a Master's of Public Health or is currently in a Master's of Public Health, Dr. Prisbilla over at UB does sexual risk behavior class, and it kind of follows a lot of the same topics that we've talked about today: pregnancy, gender affirming care, LARCs, contraceptive in general, comprehensive sexual education. So if you want to learn more about those things from a public health perspective, I'd highly recommend that course. Did you want to pop over back to Emma's question real quick before we move on to
Yes.
I also want to give a major shout out to Chris Weiser, who was very instrumental in helping me set up this meeting. Thank you for being here today.
Oh, you're welcome. I'm going to say that it was Ashley Marcantonio, though. She's our administrative coordinator and the wizard of everything schedules. So, yeah, I think Dr. Potter was queuing me up to help her with that one. So
hey, Chris.
Yes.
Hey, Chris, before you get going on that, first of all, Samantha, I want to take that class. I just want to go back to school. Secondly, if you guys are interested, just because it's related to what you said, I'm also part of this group in Rochester that's out of the public health department called the LARC Initiative. And the idea is that we go around and lecture to community leaders, not necessarily medical people, but like camp counselors at the Boys and Girls Club or like summer counselors at the YMCA. And we talk to them about like, what the heck is LARC? And it's not medical, it's supposed to be community oriented. And there's some really, really impressive data about the increased use of LARC in the basically zip codes in Rochester amongst women who are 15 to 25 years old. It's very impressive. So I jumped on that project about 3 or 4 years ago, and it's been in existence for almost 10. So I can't actually take credit. I'm just one of the little lecturers. So anywho's, Chris, will you tell a little bit more about what we're doing to expand access to the telehealth?
Sure. So, you know, you're going to get a little insider information because some of this stuff is like plans that we have that are, you know, super cool. But I will say this. So to answer the initial question is, you know, does it look more accessible? And I'm going to say yes, 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 a million times yes, because if you think about a teenager, right, who hasn't accessed healthcare on their own ever before, but now has a need to, and can do it through telehealth. They don't have to go to a building, wait in a waiting room, do all that stuff. They can just log in, and that is super accessible. In fact, there's a couple of things that we're doing around that. So I oversee programs at Planned Parenthood, so lots of external programs, and you know, there's 3 education departments between Syracuse and Western New York, Buffalo, Niagara Falls. We have youth drop-in centers. We have offices for Restore Sexual Assault Services. And one of the things that we're trying to work in right now is actually having an office that is for telehealth. So if our youth are, you know, playing video games at the Connection in Niagara Falls, which is a youth drop-in center in Niagara Falls, that becomes their waiting room. And their appointment is in the room to log in on their own without anybody, you know, having to be in there with them when it's time for them to log in. And so that's totally accessible. They don't have to travel anywhere. They're in a comfortable environment. They have a, you know, confidential space. And we're trying to put those kind of rooms in all of our community sites just to you know, provide that access. The other thing we're doing is, you think about telehealth, you need at least a telephone and, you know, probably a computer and an internet connection if you want to take it all the way to like video chat and stuff like that, or a smartphone. And there is such a thing as the digital divide, right? And especially now during the pandemic, where people's incomes are being undermined, their phones can go on and off, their internet access can go on and off. And so we recognize that that is a huge barrier to care. And so what we're doing now is we're doing some pilot programs where we're literally taking internet and a tablet to people so they can have a telehealth visit. So what we're reaching out in all the places where we might be likely to find them. The food pantries and soup kitchens are starting to get really busy. So that's a place where we're going to find people who are like, you know, struggling financially and maybe could also want to visit. So we're trying to also figure out how to bill for that, how to make it part of a sustainable model so that people who are, you know, even before the pandemic, there was a digital divide and there were people on the other side of it. The pandemic has made it a lot worse, but you know, it's definitely a need whether there's a pandemic or not. So, you know, we should be done with that, you know, mid 2021 to figure out, can we do this? And do we have to advocate for some policy changes at the state level? So we're working with national and state entities, and we're doing it with actually a couple other Planned Parenthood affiliates in New York State. We're focusing on rural and urban settings. So we're, you know, recognizing too rural poverty is a big deal, and it's often overlooked, and this pandemic is really hurting people that live in poverty in rural areas, even more so than folks in the cities. So that's what we're doing. And we have more ideas on how to build on that. We're also doing this, if we're using educators, there's some prep that could be done. So when an educator comes out, they could get some information on contraception, like what are my contraceptive options, so that when the telehealth visit does start, it makes it more efficient and quicker. So because they've got a lot of information already, and then Dr. Potter would just be like, oh, did you hear that? How did it go? You got any questions? Instead of having to do that kind of thing herself. So, that's where we're going.
Thank you, Chris.
Dr. Potter, can you answer that one?
Yeah, Allison's question. So Allison's question is, are PP telehealth services broadening across state borders? And my short answer is yes and no. So Allison, the short answer is prescribing medications across state borders. The legality of that it's state dependent, and it's also license dependent, depending on if you are, a nurse practitioner, a PA, or an MD. So after we did a little bit of digging into the legality of sending prescriptions and working with, we have some support at the state level as Planned Parenthood to kind of look into the legality of these things. We felt like that was a little too risky to do, to be sending prescriptions across state borders. We absolutely see patients from out of state all the time, particularly at our Buffalo site. We see a lot of patients who drive to us specifically from Erie, Pennsylvania, which apparently has like no reproductive health care services from what I can tell. And so we see a lot of patients coming to us, not just for abortion care, but also for contraceptive care and other needs. So that has been our approach. We will certainly see people from out of state on site, but via telehealth, legally, we decided not to. But there is a national service, Chris, I am blanking on the name, PP Direct, right? Yes, okay, there is a national Planned Parenthood service called PP Direct. Sorry, they all have these like cute little names and I forget all of them. PP Direct will see people, I think it's like literally by screen. I'm not even sure if they do a visual or if it's just kind of an automated system where you do a question and answer. And they will provide folks with prescriptions for things like birth control or PrEP via that automated service. So no from our local Planned Parenthood level, but yes, nationally. And part of it gets very tricky. Like part of it was like, well, we can probably definitely send prescriptions for things like antibiotics, but sending a controlled substance, unfortunately, like testosterone over state lines seemed far more risky. So then it just seemed difficult to say, well, yes to this, but no to that. And don't even get me on my soapbox about why testosterone is a controlled substance, which it shouldn't be at this point, but it is. So I hope that answers your question.
There seems to be a lot of it walking around, right?
Exactly.
Dr. Potter, if I could just interject real quickly. I have a very quick question. From the provider standpoint, we have medical students, pre-health students on this call. What bit of advice would you or anybody, maybe even Chris, give to aspiring medical professionals on how to necessarily utilize their education in a telehealth setting? A lot of times I think we expect medical care and medical education to be in person. You're seeing a patient, and that may not necessarily be the case for those who are either graduating soon or graduating in the future.
Well, first of all, I will say the job I had before this, I was faculty at the U of R, and I ran the primary care clerkship for the medical students, which is the clerkship in your first and second years, where you like go out and work in the offices a bit, but we also do some lecturing, and it's like how to take a history and how to do a physical exam and all those basics, right? And I really pushed when I was in charge in the past 5 years, so not recently, but a couple of years ago, I really pushed for us to start teaching people how to manage an electronic health record, Because let me tell you, when I got out into practice, I was like, I know how to treat a UTI. I know how to treat blood pressure. I'm like, medically, I've got this down. But the most stressful part of my job was managing my inbox and getting all these results and trying to figure out where do I have the time to do this in combination with seeing patients. And so I really pushed for us to start teaching the skill of managing an electronic healthcare record. So if I were still in that position, right now I would be saying we need to start a curriculum around how to deliver telehealth care in the same way that we talk about patient-centered care in the exam room. So a little bit of a diatribe here, but I think we're going to need to do a lot of research on this. And I get a little frustrated in medicine because for those of us who've been in medical education for a while, everything comes back to what does the evidence show, right? We talk about evidence-based medicine all the time when it comes to drug treatment plans for a particular indication. But I don't see us doing a lot of good, robust evidence-based research around what are the delivery of care methods that lead to the best outcomes for patients? What's the morbidity and mortality data around patients who have email access to their providers versus patients who only have telephone access? We don't really have a lot of data. We're making like a lot of gut-based decisions right now. So this is my plea to all of you who have like research brains, because I don't, to please do research on this in the future. And then I will say, as a family medicine doctor, I do not feel super limited by screen with my patients. I really don't. I feel like the vast majority, and my husband's also a family medicine doctor, so we joke sometimes like, what are we actually doing for patients? Because a lot of what we do for patients is we talk, is we do motivational interviewing, is we, help them to identify what solutions are going to work for their lives. So when I'm providing gender affirming hormone care by screen, I don't actually feel that limited. I still have that visual connection with the patient, so I can still see their nonverbal cues. I can still get that kind of feel from them. And so I don't always feel particularly limited by it. So I have a lot of hope for telehealth. I think I'll admit when I first thought about it a couple of years ago, well pre-COVID, I was like, that's going to be terrible. I won't connect with the patients nearly as much. So I've been pleasantly surprised. And I will say, Chris mentioned this, and I think finding different ways to name this is going to be important. But for folks who have felt marginalized in clinic or hospital settings previously, I actually think this improves my visits with those folks who maybe have experienced trauma in medical settings previously, whether that be trans folks who have literally been harmed by medical providers before and who have like physical PTSD reactions to being in a clinic or being in a place where they've been repeatedly misgendered or harmed. In some ways, I feel like my trans patients do better on screen than they do when they're sitting in my like sterile white-walled office and me sitting there with my stethoscope on looking really intimidating. So I have some hope, and I think there's some opportunity here. That being said, you're not going to get taught how to do it, just to be clear.
I have one of my best friends is actually a M1 at Upstate, and we've kind of been having these conversations about like, what is your medical education going to look like in a pandemic? Like she started her first semester, like not being able to really attend anything outside of a virtual classroom. I'm currently in my second year at the MPH program at UB, and like all of these changes are happening. And speaking to what Chris said earlier about the digital divide and how like we're really seeing the effects of that is just like really heartbreaking, because like we know the solutions, like we know what needs to get done, but like, is the money going to be there? Is the support going to be there? And what you were saying earlier, I think really resonated, like the gender affirming care and having that screen as a barrier. I think we undervalue that prior to COVID, how being in the medical setting can be very scary and very traumatizing and re-traumatizing to certain individuals.
Exactly. Yeah, definitely.
Yeah, I'd like to add to that too about the digital divide. So a lot of the problems are regulatory too, because we have tried some things, not necessarily Planned Parenthood per se, but like we are involved in lots of collaborative work with different organizations and funders. And we actually tried to set up free Wi-Fi nodes throughout Buffalo so that really anybody could log in. And actually money was put into it, and some of these actual hardware got set up, and the FCC came in and shut us down because the regulations, they control the access to internet, and doing what we were trying to do isn't allowed. So so there's a lot of advocacy as well that needs to happen to get better policies, to review regulations that make sense. We could, like, all of Buffalo right now could have free Wi-Fi paid for by Buffalo donors, you know, basically, not even the state, but it was shut down. So
this is like one of the things that I will talk about all day long, but like it took federal intervention for the entire United States to have electricity, right? Back in the 30s, like
yeah,
electricity was like not a utility, and like internet needs to be a utility. Access to internet shouldn't be something that students have to fight for. Like if you are low income, if you live in an area that doesn't have the utilities needed to provide broadband, like we need to get on that. My dad works for Verizon, and like that's his job, is basically he installs home phone and internet, and he goes to like the same areas every day. And I'm like, how great would it be if you could go to like Jamestown and just like make sure everyone in Jamestown had internet?
right.
Everybody.
Switch on Jamestown.
I know I didn't mean to pick on them, or mean to pick on
I brought him up. It was my fault.
Why is it that why are we treating internet more as like a privilege or a right than, more as a privilege than as a right? Because
Yeah, and
we're expecting so many people to be able to connect virtually. And I mean, this is a perfect instance. Like the people who were able to attend today, like knew they had reliable internet. So
Right.
that's my.
and that's the importance of
Definitely.
advocacy. And honestly, if I can too, because I have for the past 5 years been participating in healthcare reform in New York State. If you want to look it up, the acronym is DSRIP, DSRIP, Delivery Systems Reform Incentive Payment Programs. And I can tell you that one of the major fatal flaws of the entire DSRIP rollout was that there weren't enough Dr. Potters at the table. And it's because they don't have time. They're seeing patients. And the reality is, no matter where you work, the financial health of the organization depends on you seeing patients with your time, right? And so there's lots of system reform that's needed, and we need doctors to be more involved in those processes instead of like sending an administrative type or a programs type like me there, who can't do the same kind of view as Dr. Potter could. I mean, I did the best I can, obviously, and I'm passionate, but she would have been better also at the table, right? And the entire effort would have been. So, there's lots of advocacy that needs to be done. There's lots of system reform that needs to be done to make sure that we're doing everything the way we should. Otherwise, it's just going to be a bunch of, partially informed enough to do damage people doing all the work. Yeah. It's not good.
Yeah.
Absolutely. I mean, in the last few minutes, I want to make sure if anyone has any additional questions. If not, I have one more question that I'm going to ask, and then we'll probably end for today. For everyone who attended, thank you so much for being here.
Thank you.
We'll have an evaluation form that you guys will be able to fill out. I want to thank Dr. Potter and Chris Spicer for being here. I mean, taking time out of your very busy schedules to come and talk to just a small group of up-and-coming healthcare professionals and current healthcare professionals really means a lot. My last question for you guys is, in our previous meeting, we had a researcher in the Jacobs School of Medicine and a physician, Dr. Michael Minka and Dr. Brooke Lerner, who were talking a lot about emergency medicine. And one of the things that Dr. Minka mentioned in his presentation was that the number of emergency visits actually decreased as the pandemic went on. So I'm wondering for you guys, did your number of visits from last year at this time to this year, did you see a major difference, or was it kind of like on trend for the same amount?
Yes, we did see a difference. And not that there's no healthcare organization that isn't always concerned about its bottom line, but obviously as a not-for-profit, stigmatized healthcare organization, we are always very concerned with our bottom line, right? Like we've got to make sure that we're bringing in enough to keep the lights on and the clinics open, and that's really our objective. And unfortunately, we have seen just a global decrease in the number of visits that we've seen this year. Now, part of that is for a few weeks in March and April, when we really didn't know much about this disease and didn't understand what was going on, there were a few weeks where I said, we will not do pap smears. Like, if you just need your routine pap smear, we are not letting you through the door. So there were some obvious reasons why those numbers went down initially. But I also think that people on the whole are more reticent to enter medical systems right now. You know, in the same way that people are more reticent to go to restaurants, and there's just that fear of exposure and really not knowing. That being said, I'm trying to think, I was just looking at our abortion numbers for Q3. I think our abortion numbers are not nearly as down as like our global services, you know, pap smears and preventive exams, but I think our abortions did go down by about 10 to 15% overall. We saw kind of an increase in birth control visits in the very first part of the pandemic. I think a lot of people were like, whoa, I need to make sure I've got something here. And now I'm stuck in the house with my partner, and like, I really want to make sure I have good birth control going. So we did see a slight increase there, but globally, yes, things have gone down. So part of this year has also been getting creative at keeping our budget on track, right, Chris?
Yes, it definitely is. And, you know, we're a little bit fortunate that we've been able to compensate in lots of ways.
Yeah.
But I do want to say too that, you know, I'm on the board of managers for SIPA, which is the Safety Net IPA, and this organization called SNAPCAP of Western New York. You can look that up.
So many fun
monthly
acronyms.
Meetings. I know all these acronyms. Basically, it's all the safety net healthcare organizations in Western New York, including the hospital systems in Kaleida. Our services didn't go down as much as others did. You know, some of them went down to 10% of their normal volume, and we never got that low. So I think that also speaks to, you know, like the fundamental value of what Planned Parenthood provides, that people just still came and still needed it and still wanted it. And even with our, you know, saying, okay, let's prioritize what services we can do right now, we still saw a lot more than most primary care organizations did. So, you know, there's that. But it still hurts. Like, if it goes down to 50%, that's half of your volume. That's also half of your revenue. So it's really hard to keep everybody employed, which we managed to do. So
that's good to hear that you guys are still able to provide those essential services. I mean, I was fortunate enough that like all of my yearly care had already been done. Like, but by the time the pandemic hit, I just always seem to do it at the beginning of the year. But it was like worrying to know that, you know, providers might be unable to see you for various reasons. But thank you guys so much for today. Everybody, thank you so much for attending. If you have any questions, please email me. I'll try to pass them along to Dr. Potter. Because this is recorded, I will be emailing everybody the recording if they had to log off, or if they just want to hear some of the information again. We talked about acronyms a lot, so if you wanted to know what some of those organizations were, you can listen back. But thank you everybody for being here today. A special thank you to Dr. Potter and Chris Spicer for joining us today. Thank you so much.
This was really fun. Thank you guys. Take care. Good luck to everyone.
Have a good week.
Thanks, Chris.